All right, good morning, everybody. We have a quorum for the EMCC meeting. All right. So we'll start with call to order and introductions. The EMS agency could start the introductions.
Good morning, Steve Brooks, EMS Agency.
Kimberly Hernandez, EMS Agency.
Karina Moreno, EMS Agency.
Devin Delaney, EMS Agency.
Manashwari Jacket, EMS Agency.
Deborah Hopgood, EMS Agency.
John Burley, EMS Agency.
All right, thank you. Could we do a roll call for members of EMCC as well?
Will Hiller,
Present.
Chris Borkin,
Present.
David Sargenti,
Present.
Jason Solons, and Cheryl Getz as alternate. Yes. Jody Schaefer,
Present.
Paul Wood,
Here.
Marie Lutz, Carla Spencer,
Present.
and John Anthony. Alternates, Mike Esslinger. Present. Mike DeLeo. Present. Thank you. Dr. Hawthorne.
Present.
Thank you. Joe Cafaro.
Present.
Thank you. And Bandy Smith. Ex officio members, Sandy Pleasant, Teresa Rios, Kelsey Scanlon, and we have your boss. We have Leslie here to replace Leanne. So Leslie, I'll mark you down here. Thanks.
All right, moving to public comment. Any member of the public may address the committee for a period not to exceed 3 minutes on any issue not on the committee's agenda. The EMCC will listen to all communications, but may not take any action.
We should let any non-members, I guess,
Oh.
if they would like to announce their presence.
My apologies. Any guests in the house would like to introduce themselves?
It's not required, unless you want to speak.
Jenna Fortis from Seneca Family of Agencies.
Thank you.
Jalen Neal, EMS Agency.
Thank you, Jalen. And I got Sam Klemick.
And Kurt Shockey from Veterans Transition Center.
Great. Thank you, Kurt.
Amanda Kipp from Seneca.
Dr. Bright, please stay present.
Thank you, Dr. Bright.
Betty Hull with the CNE here. I'm the CNE at Soledad. Thank you.
Heather Taher, AMR.
Thank you, Heather. Okay, at this point, I would like to point out that Kurt Shockey is, we're working on him to become a member of this, of the EMCC, and he's dropped in to be here. And we'll introduce him formally once we get the whole process through, but I want to thank you for being here today.
My pleasure. Thank you.
All right, so we'll go to approval of past EMCC meeting minutes. We could do a verbal vote.
Need a
motion?
Motion to approve. Thanks.
We have a second.
I'll second.
All right,
Thank you.
all in favor? Aye.
Aye.
Any opposed? All right. Moving on to standing reports. Item A.
Teresa, please feel free to bring those to me instead, and we'll get you the help that you need with them. An update on hiring processes. We have posted for 2 EMS analyst positions. The application submittal period for those has closed. We're currently in the process of reviewing applications. We hope to have interviews arranged and scheduled before the holidays and have somebody on board within the first quarter, 1 or 2 people on board within the first quarter of 2026. We, as many of you have heard in the past, we also have the health program coordinator position that's been open. That's a shared position with public health and other bureaus within the health department. Because of that, it's not specifically tailored to EMS, and we've had some significant challenges around that and finding candidates who meet what we need as far as somebody who can work on our quality improvement programs and our specialty care programs. Given those challenges in the past, we've made the decision to work towards implementing a new position that will be more tailored towards EMS. So more of a quality improvement coordinator type position. We're just in the very early stages of that, putting together a job description that's gone to HR and waiting to hear feedback from them on that. It's a very lengthy process, as you might imagine, to bring a new position into the county. So we don't really expect any changes with that or any new potential staff for probably up to a year, if not more. So, but we are wanting to get the ball rolling, just really due to those challenges we've had in the past. Let's see. Otherwise, the 2026 policy and protocol cycle is underway. Staff has been working really diligently on that. They're currently working to wrap up our responses to the public comments that we received. I'd like to thank everybody that submitted public comments. We had a lot of good responses and good points that were brought up during this public comment period. So we expect to publish those responses by the end of the week. After that is done, we will hold 3 meetings as we've traditionally done in the past to answer any questions or anything else that might come up subsequent to that before they go to CCC in March for endorsement and approval. We have also started working on implementing a software for electronic submission of applications for EMT certification and paramedic accreditation. So we are in the very early beginning phases of that. We're working on sort of a design and development process with the selected vendor. There will be much more information on that, and that comes out prior to the actual implementation of the software. So that's a little ways off, but we'll get more information to you. EMS agency staff also recently presented at the Law Enforcement Crisis Intervention Training. That's something that we've been doing the last few sessions that they've held. We co-present with the chief of police from Monterey Police Department and a member of the behavioral health staff. We're able to kind of provide the EMS perspective on the policies and protocols, and I think it's a really good interaction for the EMS agency and a good opportunity to talk to some of the law enforcement officers that are working in the field and share some EMS perspectives and hopefully make those calls go a little smoother or let them feel that they have a chance or someone to go to if the calls aren't going well and that they can get some assistance with sorting out some of those interactions. So otherwise, I would like to take a moment to acknowledge that Natividad has recently completed their trauma re-verification procedure. They went through the final steps of that process last week. It's for anybody who hasn't been through it, it's a very, very lengthy process. A very thorough review of a large number of patient charts, policies and protocols, the specialty services that they provide, and review of equipment and things like that within the hospital. So Natividad went through with flying colors. They had no deficiencies identified. So we expect that soon they will receive their re-verification for another 3-year period. So it's a huge accomplishment on their part and a very onerous procedure. So we're happy to see that, and we're happy to see those trauma services continue in the county. Otherwise, we have an agenda item for the RFP and the EOA transition, so I'm going to defer other items till that time. And if anybody has any questions, I'm happy to answer them.
All right, thank you, Deborah. Dr. Burley.
Thanks, Will. We just completed our CCC meeting this morning, and just a few items from that. We heard from Kimberly regarding APOT times and the state implementation of AB 40. The data alignment is not 100%, shall we say, between the county and the state. So we're continuing to work on trying to make that as well aligned as possible. We heard about our HDE implementation. which is doing really well. We're matching at about in the mid 90 percentile range, which is fantastic. We heard from Deborah regarding a continuation of our buprenorphine LOSOP, which expires at the end of December, and we have submitted an application to EMSA to continue our program, which is not requiring any specific changes, so that should go through without difficulty. The 2026 policy and protocol review cycle was reviewed as well as some responses to public comments. We also had a presentation from Seneca Pediatric Behavioral Health, as well as the 911 Nurse Navigation Program for GMR, both of which are scheduled to present at this meeting, so I won't get into too many details regarding that. Those were the primary things that we discussed at CCC. Happy to answer any questions.
Thank you very much, Dr. Burley. Deborah, for the MOAC report.
Yes. EMS agency staff recently met with the newly appointed regional disaster public health representative. This is a position that the state has implemented that's designed to work sort of in concert with the regional disaster medical health specialists. So in the event of disasters, large-scale incidents, pandemics, that sort of thing, we can tie in more closely with the medical health EMS response side of things, hospital side of things, with the Public Health Bureau, and they can work together and we can get resources in a more streamlined fashion. So we'll see how that develops as time goes on. Like I said, brand new position. He's only been in his spot for a couple months now. So, but I think that'll be a good addition to the disaster team. We've also been participating with Public Health and the Healthcare Coalition in the planning for the 2026 Medical Response Surge exercise. So we've held a couple meetings so far, developing what the MISL will look like and the injects. We're meeting later this week to talk about EMS specific injects and how we might more incorporate EMS into the exercise. So I think that will be good. That first exercise is scheduled to take place on April 3rd. We also recently participated in a drill at the EOC. It was sponsored by COAD, or Community Organizations Active in Disaster. It was great to, get back into the EOC, talk to some people that we don't necessarily get to talk to, share some information about the MOAC program and what we do in EMS, and get to know some people before you have to get to know them in the middle of a disaster. So good experience, and I don't have any other updates at this point, but again, happy to answer questions.
Thank you very much, Deborah. Okay, moving on to EMS system performance metrics. Kim? Looks like items A through E.
Good morning. The ReadyNet drill and 800 megahertz testing results were included in your agenda packets. Nothing out of the ordinary there. We continue to report results to the hospitals as we receive them from AMR and work through any concerns as they arise. Any questions on 800 megahertz or ReadyNet? Okay, I'll move into contract compliance. So a contract compliance report was included in your agenda packet as well. A quick summary, all reportable priorities for August and September met or exceeded 90% compliance, and percentage of calls going through EMD remains to hover around 75%. Any questions on contract compliance? Okay, thank you.
All right, so moving on to old business. Item B, health data exchange.
Yeah, so I don't really have anything formal to report on this. The ESO reports, as Dr. Burley mentioned, for our transport providers are showing really promising.
Thank you, Deborah. Moving to item D, 2025 EMCC appointments, reappointments, Steve.
Yes, thank you very much. The good news is that we've found a couple of individuals who are interested in serving on EMCC as citizen representatives. So they're very well qualified, and we'll be moving them forward to through the board approval process here, and should be joining us at our next meeting. So very, very happy about that. We are continuing to seek members for alternate positions, and to be able to step in, when some members who are looking to, step aside, or, we'll give them the opportunity to do that. So we're moving forward that way. As far as appointment, as far as some of the paperwork issues, I got bogged down last week in trying to find that we have everybody's oath of office. And so I may be reaching out to you for a copy of that if you have one. Otherwise I have to go to the clerk. And there's several documents like that. Also, Form 700 is going to be coming up. So if you've completed that with another agency, that's all grand. But we'll be looking for those about the time we meet next time. So there's some paperwork that you guys are going to need to do related to EMCC appointments. Any questions?
Get a reminder on Form 700 to our email, or auto remind?
We'll make sure you get one.
Okay.
Yeah, but because we get the same form, and then we'll just make sure you guys all know. And you'll get one from me. Because we want you guys to do it. We want you guys to see a part of our happy band. Any questions or comments? All right, thank you.
Okay. Moving on to item E, 2024 EMCC Annual Report.
Went to the board, and that should close that report.
All right. Item F, PCR data standardization. Deborah?
Yeah, I don't have a report on this. Teresa had been planning to bring an update to the meeting, but we've placed the project on hold until her return.
And item G, EOA ambulance contract transition.
I'll take that one. So the EMS agency staff is continuing to hold weekly meetings with AMR to review their progress and outstanding deliverables as well. Those have been going well, and I think we're making good progress towards our objectives. The EMS agency, along with AMR, held a meeting with fire representatives on October 27th. We provided a presentation on some key points from the new agreement and AMR's proposal, answered questions related to that, and it seemed to be generally well received. We also have been working to arrange a similar meeting with the EMS agency, AMR, and the hospitals. We originally had this scheduled in November. The hospitals had asked to bump that meeting back a little bit, so we're now meeting on December 9th. Separately, AMR has reached out to the hospitals regarding the transportation management platform. This is a tool that's aimed towards making interfacility transfers a little easier to request and make the process streamlined for the hospitals. So we are hoping to arrange individual meetings with the hospitals to address their concerns prior to the December 9th meeting of the general group. So please, if you haven't done so, and you're a hospital representative, make sure you follow up on that request so we can get those scheduled. The goal with that is then to be able to answer any questions, any follow-up at the general meeting for the whole group. So we have several related agreements that are in various stages of progress and moving forward, primarily for mutual aid services, with ECD for dispatch space and equipment, and then with First Watch as well. First Watch is going to be a really key component for the new agreement as far as managing response times, managing Pro QA and EMD determinants, and then the new clinical scorecard that's a key piece of the contract. That's a big change for us and a big development, and I think a really good progress thing for the system, in that we'll start looking at clinical metrics as well as response times. So not only how fast are we getting there, but are we doing the right things once we get there? So in furtherance of that, we had a couple of EMS agency staff who went to the First Watch conference, got some training related to the program, and I think that will assist in the initial setup of the program and then the use of it down the road as well. And then we have a presentation on nurse navigation scheduled for later, so I'll save any updates on that until that point. Happy to answer any questions, or Mike, if you have anything you want to add.
If I can, I just, on behalf of the hospitals, so we have been talking as a group. We do have a pre-meeting before the December 9th meeting. We do have some concerns specifically around transfers in the critical care space. And so we will bring that to that meeting. What you're speaking about the new transfer platform, I'd like to know more about that. I have not been contacted. I don't know if somebody else at Salinas has, and that's okay.
David Thompson.
Okay, that's fine.
He reached out to me yesterday.
Okay, so I haven't heard anything about these separate hospital meetings that should happen before the December 9th meeting, so I'm interested to know a little bit more about that as I, coordinate sort of with the whole group.
Yeah, Mike just reached out to schedule those.
Yeah.
Okay.
And from your facility, I reached out to David Thompson. He
Okay.
was the single contact and he responded yesterday.
Okay, perfect.
So our plan is to actually have individual meetings, so that way if there's, specific issues, with your facility that might come up, that would give you an opportunity not to have to discuss it in a forum with all the different hospitals.
Okay, that sounds good. I'm going to put out an email to the whole group so that everybody, we want all the stakeholders that need to be in those meetings. That way we have good communication.
And I can
across.
forward you the original email that I sent. I actually provided an overview of what TMP is as well and all those things.
Perfect. Okay, thank you.
All right, moving on to new business, item A, CSA 74 distribution. Corinna.
Hello, everyone. In your agenda packets, you received the CSA 74 allocations for fiscal year 25-26. The calculations of the CSA 74 distribution follows a prescribed methodology that includes workload, which is emergency medical calls for each jurisdiction's population, assessed value by taxing agency. We plug the data from each category into a formula to come up with a calculation of the distribution for each jurisdiction. Devin, can you zoom in a little bit? Is that better for everybody to see? And then scroll to the right. It's not gonna help. Okay. But the distributions are in your agenda packets. And then can you go to the year-to-year comparison? We share the year-to-year comparison to watch for any major fluctuations that there may be. Does anybody have any questions on this? And if you want to go back maybe to the, and they are in your agenda packets, but if you didn't get them, I can email them to you as well. We are seeking endorsement from the committee to move forward with the distributions, which according to the MOU has to be by December.
All right, thank you so much. So we'll do a roll call vote to approve.
Thank you. Roll call vote to approve the proposed CSA 74 distributions.
Steve, should we have a motion for endorsement first?
Oh, yeah, thank you.
Yep.
Got the intent, but yeah, sorry. I gave you guys the motion without getting you guys give the motion. So anyone want to make a motion?
Before I make a motion, I would check in with Chief Sargenti. Everybody good with what this is?
Yep, it's a standard protocol we've seen in years past.
And I'll go ahead and make a motion to approve this distribution. Did I say that correctly?
Close enough.
Okay.
We'll write it well for you.
Okay, thank you.
And I'll second it.
Thank you. We have a motion, a second. Will Hiller?
Aye.
Chris Borkin?
Aye.
David Sargenti?
Yes.
Cheryl Getz? Jody Schaefer? Paul Wood?
Yes.
Carla Spencer? Thank you.
All right, moving on to item B, AMR nurse navigation.
Great. Well, let me start off. I would like to introduce Steve and Eileen, who are from GMR's Nurse Navigation team. I want to say that, it's a program that all of us at AMR are really excited about. We believe that this is going to be an essential program for us, but also an incredible enhancement for the EMS system. So with that, I'll leave it to Steve to explain the program, and we'll look forward to, we'll have some, some time for questions as well.
Awesome. Thank you, Mike. As he said, my name is Steve Moffett. I am the Business Development Manager for Nurse Navigation. Now, when we talk about EMS in its current state in 2025, things have changed. Call volumes are going up, as we all in this room have seen, and it's very hard to not respond in some way to those, right? We've also been able to, over the years that EMS has been doing what we do, we've been able to get a lot of data. And what we've been able to see with the data is that response times, especially for low acuity calls, play very little role in the outcome of the patient and how well they do. We know that in EMS, the percentage of actual life-saving interventions we perform that matter are very, very low. It gets a little higher once you get to the ER, but still, especially for low acuity calls, the incidence of us having to actually do something to save this life is very low because they need something else. We also know that turnover is a real thing and it is not changing. Coming from being career EMS second generation, I can tell you, I saw where back in the day, when your demand went up, you threw more supply at it. That's just what we did. Demand would go up, call volume goes up seasonally, or hey, we've got a new subdivision that opened, that's fine, let's put more trucks on the road, let's get more people hired. We're at a point where that's not necessarily possible because we've kind of hit a inflection point where we don't have more supply to throw at this. So what do we have to do? With the supply and demand, it's an equation. We have to reduce the demand. That's where nurse navigation comes into this. Our goal with nurse navigation is to reduce the amount of responses to the low priority calls to free up those apparatus and those resources for the patients that need them the most. It's also with the intent of making sure that patients are getting to the right place at the right time. Not every patient we now know needs an emergency room. Sometimes going to an emergency room is going to delay their care for other things, and our goal is to get them to the right place. What you see on your screen, if you look at the top here, that is current state. It's what we do, it's what Johnny and Roy did, it's what we've been doing for years. 911 call goes to the dispatcher, gets the information, dispatches apparatus, apparatus gets on scene, assesses, treats, and transports. With nurse navigation, what we're doing is we're throwing in a different aspect of this, a different option for the dispatcher. Now, for those patients that meet our determinant code criteria and the ones that we have identified as being safe, we can send those to a nurse. The nurse has two jobs. Number one, they're a safety net. Some things based on how you answer EMD questions are it guides you down a path. Sometimes some things will slip through on those questions. They're the safety net to make sure that a critical patient doesn't get missed and doesn't get the wrong resource. Great example of this that I use is abdominal pain. Might be a low level abdominal pain, a 1 alpha, gets to the nurse, they start asking a little more probing questions, a little more in depth. Patient goes, oh yeah, actually it's like a tearing sensation in my stomach. Oh, okay, well that needs ALS resources, that needs that priority response and that life-saving intervention. So they're that first step. But they're also the step of asking those questions. Our nurses are trained in emergency medicine. They're trained to ask questions the right way in order to properly assess the patient and figure out what's actually going on. You might be a 1 alpha, but why? What else is going on? And then from there, they determine where to get the patient to. They use what we call the NMTARA algorithm, needs matched, time appropriate resource allocation. What do you need? How soon do you need it? How are we going to get you there? At the bottom, you're going to see the various options that they have. You can go with self-care. Some patients don't need to actually go anywhere. Sometimes they just need to know, what can I do for myself to take care of myself at home? An example of this would be maybe you have a new mom, has a baby, has a fever. I don't know what to do. Well, we can walk you through. When did you give ibuprofen? How much ibuprofen have you given? How large is your child? And walk them through kind of how we can do that and get them taken care of at home. Some communities have virtual care or MIH programs. This can be a great air traffic control for MIH. Make sure that MIH is being used in the most efficient way possible. There's also community care resources. Not every patient needs an ER. Maybe they just need an urgent care. Maybe they need a dental clinic, a behavioral health clinic, something, one that we use a lot is FQHCs. Maybe they're uninsured or underinsured. Well, instead of going to an emergency room every time they have a chronic issue, maybe they just need to actually have a primary care physician, get enrolled in Medi-Cal, and get the proper care so that they can take care of themselves over the long term. And then we do have these patients that, yes, you need an ER. ER is still the most appropriate way to be cared for. But that doesn't mean that you need a ALS ambulance, lights and sirens to an emergency room. Sometimes there's other ways of doing this. And so we can work with the patient based on the data that we have to figure out, okay, you're probably safe to go in a ride share. Let's get you an Uber to the ER, or we can call you a BLS ambulance. A BLS ambulance is going to transport you, that is going to be not taking up a valuable ALS resource in the 911 system, but getting you still to where you need to be. This is also true of those patients who may not necessarily need an ambulance, but maybe they're having mobility issues. If I say, I'm going to call you an Uber, meet them on the sidewalk, they're going to take you to the emergency room. Well, I can't get to the sidewalk. Then an Uber's not going to do you any good. So I'll get you a BLS ambulance and they can help you get to where you need to go. When you look at programs like this, I think we can all admit this is new, this is different, this is not how we have been doing business for a very long time. So there is a staged maturity process. This is a crawl, walk, run scenario. Because at first, if we went all out, threw everything at it and said, yep, open the floodgates, it's gonna fail. You need to get everyone used to how this works. So your stage one, you're looking at about 3 to 7% of your total volume for EMS calls. What this is doing is it's getting the community used to it. It's getting the PSAP and dispatch used to the process. And it's making sure that everyone's kind of on the same page, understanding this is a new way of getting care and making sure that that gets adopted. Phase two, you're looking at about 7 to 13% of your total EMS call volume. This is where, all right, now we're up, we're walking, we're going. Now muscle memory is starting to hit in. Dispatch is used to how this works, and this is your stabilization. All right, we're good here. You get to phase three, this is the fun part. 10 to 15% or more of your total EMS call volume. This is where everyone knows how this works. Everyone knows what to do, how to do it, and this is where you can start having fun with it. You can explore new areas to expand this into. You can open up your determinant codes. You can start doing research and data acquisition to support what you're doing and figure out, am I doing the right thing? Where can I do better and how can I do better? And this opens that up there. Now for outcomes and benefits. Where do patients go and about how often do they go there? What we're seeing here is this is an average based on what we do nationally. What we've seen is that there are still about 3% of patients who need an ALS response. Those ones where they answer the EMD questions honestly, but maybe it didn't get deep enough, or the nurse caught something else that was a secondary issue that said, nope, that's an ALS response, right back to the PSAP, we're gonna get you the apparatus you need. That top orange area, what you're seeing there, those are the ones that need that BLS transport still, whether it's mobility issues, they just need maybe some BLS monitoring to the hospital. This is also where patients, because we have built in sort of a Pavlovian response in the community of you call, we haul, there are some patients that do not want to engage with the nurse. We're never going to not send you an ambulance. We will never refuse someone an ambulance. They say, nope, I don't want to answer your questions. I'm done. Send me an ambulance. Okay, we will send you an ambulance. This is where we send the appropriate resource based on what their determinant code would have been. When you get to the yellow portion here, this is the rideshare part. These are the patients that still need an emergency room. They might need access to resources that the ER has that maybe an urgent care or a primary care doctor's office does not. But this is where we're getting them out of the EMS system. We're not tying up resources and we're getting them rideshare or POV to the ER. The green section down there, this is where the patients are not seeing an emergency room. They're not tying up triage. They're not tying up a bed in the ER that another patient may need. This is where we're getting them to community care resources, or we're getting them self-care at home. Now, a program is only as good as the foundation it's built on. We have the supporting infrastructure to make sure this works. right now, you've got the NIMTAR protocols. They were based on, if any of you are familiar with the ESO white paper, ESO is in the unique position of having a software solution that goes from dispatch to discharge. So they were able to follow patients in non-nurse navigation areas from dispatch to discharge and say, based on what that was dispatched as, and based on what the hospital ended up doing for the patient, we believe that these are the safe calls to hold, safe calls to navigate to another location. ESO's dispatch, the data they acquired was about 1.75 million patients. So they took a huge portion of data to determine what was safe and what was not. To add to that, within nurse navigation, we're currently at 250,000. By the end of the year, we'll be about 250,000 successful nurse navigations without having a negative outcome. So we have not had a negative outcome in those 250,000. This year alone, about 75,000 patients. So the infrastructure is there. It's been physician developed. So our medical directors, Dr. Troutman at GMR continues to work with us to figure out, again, are we doing the right thing? Is this working? What should we change? Should we change anything? Our comm center, you'll see a picture of that there. That is our comm center in Louisville, Texas. It is co-housed with our national flight center. It looks like any PSAP that you'd walk into, except that those are nurses there, they're answering the phones. Our comm center is staffed 24/7. I know it says 50 nurse navigators on staff. We're up to about 70. Our staffing has increased drastically. We have one in Texas. We also have one in Phoenix, Arizona, staffed 24/7, days, mids, and nights. Everyone is there. And we also have the ability to integrate with whichever system it is that we're working with. We have the technology stack to make sure that that happens. The other nice thing is we have the technology through Power BI to go through and look and provide real-time data on what every system is doing so that all pertinent stakeholders within a system can look and say, how are we doing? Is this effective? What's happening? And you can get that data real time. For the experience part, a system or a program can't be successful if people don't like using it. If you have a program and it's clunky to use, it just doesn't get where you need to go, people are going to stop using it. They're not going to be happy with it. What we've done is we've been able to go through and first calculate how long does it take for patients to use this? Is this something where they feel like they're sitting on hold every single time that they're using it? We have averages, about 25 seconds from the time a EMD or a dispatcher sends the call to nurse navigation until the nurse picks up the phone. Total time is about 12 minutes to figure out, 8 to 12, to figure out what's going on with the patient, where do they need to go, and how do we need to get them there to fully implement your NIMTAR algorithm. If they're going to go telehealth, it takes about 18 minutes total to get them on with a telehealth provider. If they're going to go to a community care resource via Lyft, total time is roughly 42 minutes on average nationwide, from the time that they get connected to the nurse to the time they get to the clinic. Which if you have ever gone to an ER, especially recently, it's probably going to be a lot less time than they would be waiting in triage in an ER, especially for a low acuity case. It's making it so that they are getting care faster and they're happier. We know that because we do surveys. Any patient who does not utilize an EMS resource, BLS or ALS, gets a survey. We follow up with them. We have people actually call them up. They ask them these questions. Do you feel like they actually understood what you were saying? Did we get you to the right place? How did that go? Right now, on a scale of 0 to 5 stars, 4.8 is our average. That's over that 250,000 navigations. 4.8, that's pretty good. People like what they're doing, to the point where in some of our more mature systems, they will call 911. Dispatcher starts asking questions. They say, no, I called last week. I talked to a nurse. I want to do that again. Okay, let's get through these questions first and make sure that we can get you there. But they're calling and they're relying on this and they're wanting this as their means of care. It also impacts local EMS system. We have the ability within GMR of looking at our business units that have nurse navigation installed and the ones that do not have nurse navigation installed. Overall, about 11.6% higher job satisfaction score in the areas that do have nurse navigation installed. When you think about this, it makes sense from a paramedic's perspective. I've been a paramedic in the field. I went through medic school, the blood, sweat, the tears. When you go through medic school, they hammer into you acute care, critical care, cardiology, medical, trauma. You learn all of that. Then you get out into the field, and if you're running low acuity calls nonstop, you're not going to be as happy because you're not utilizing what you fought so hard to learn. Now, you're able to, on a higher percentage of your calls, use the information that you learned. It's going to make it so that you're happier doing what you're doing. You're happier getting to work, which goes back to the whole, remember, we can't recruit and retain people because they're going somewhere else. This is making it easier to recruit and retain people and building healthier EMS systems. This is I apologize for the busyness of the slide. I didn't make it. But this looks at the last 12 months of what we've done within nurse navigation. If you look at the bottom right-hand side, you're going to see that there's a map there. All of those sites are nurse nav sites. The ones in white are the ones that are currently active, up, running in various stages of maturity. The ones in gray are in current implementation phases. This started as one spot. That one spot was Washington, D.C. 8 years ago, DC FEMS came to us and said, you're our partner in the system. Our system's broken. Please help us. This was let's figure out how we can just do this as a one-off. It took hold, and now it has spread. By the end of the year, most of those sites in gray are probably going to be up and running or close to it, with more implementations to come. More and more people are adopting this because they see the need for it. We talked about the maturity level of systems. It's a 3-stage process, right? Stage 3, when you hit full maturity, this is where you can start having fun with it, because now you're getting data. More patients are getting sent to nurse navigation. Now you can start playing with this. Seattle Medic 1 did this. They were an early adopter of it. They're a partner of ours. We provide their BLS 911 system transport. They looked back, and once they had been involved for 3 years, they said, all right, 3 years in, let's see if we can get some data out of this. What can we do with this? So they looked back over the 3 years, 20,000 navigations, a little bit more than that. They were able to look and do their own patient satisfaction scores and say, are the patients happy with what's happening? Yes, they are. They're also able to see the operational impact, the time on task. Are crews becoming available for the patients that need them the most? Are we operating as an efficient EMS system for the community? They are able to prove by their data that we are. They are also able to show that the community is benefiting in different ways. They looked at, all right, if these patients, they all called 911, if we would have taken them to the ER, how much would that have cost? And how much would that have cost the community health system as a whole? They determined that based on those more than 20,000 navigations, it saved the community healthcare system close to $20 million. That's a huge impact to the community healthcare system. Those are dollars that can now be spent other places because it's not being spent on patients that are getting the wrong level of care. They also determined that, all right, we have heat maps as Seattle of where our people are. We have the data of where our nurse navigation calls are coming from. They're able to overlay those. They determined that most of the nurse navigation calls were coming from areas that were underserved from a healthcare perspective. They were coming from low-income communities where patients were uninsured, underinsured, or they just didn't have adequate access to care. Now these patients are getting that adequate access to care and being able to carry that on long-term. I'll leave my contact information up for those on Zoom. If you want to jot that down, if you're in here, let me know. I can give you my card, or you can get Mike or Eileen's information as well. Are there any questions?
Okay, go ahead. Sorry, I was gonna say, I have a lot of questions.
Go for it.
And I'm wondering, we probably need to, maybe meet offline with the hospitals, but I think there's several questions that are coming in right now. So I'll just put that out there. Maybe we could work together to
Yeah,
make that happen.
and I will state, you know, as far as the implementation is that we have 5 work groups that we're putting together.
Okay.
And, you know, from the ground up, the hospitals, fire agencies, various groups are all going to be part of building the program with us here in Monterey County.
Okay.
A couple of things to add is, well, I can't pay for the trip. You're welcome that if you wanted to go to Texas as well and spend a day in the center. For me, it was really valuable. I was able to go there twice actually, and very profound to watch some of the cases that come in. I did get to watch a little of some of the patients getting pinged back and forth where, you know, the PSAP would actually send the patient to nurse nav. They would kind of do a little bit more interrogation, send the patient back to 911. But what I did witness that was really incredible to me was, you know, one was an elderly woman who she had been recommended to go to urgent care within her same hospital system. She had no way to drive. They had recommended that she use Uber. She says, I've never used Uber or Lyft. And I got to watch the nurse do all the arrangements for her. And what's really important about the program is that it's no cost to the patient at all. In fact, she asked about tipping the driver. They were very clear. You don't tip. You just, here's what time they'll be there. You just go out front. Not only did they take her to urgent care, but they actually arranged a ride for her to be brought back home at no cost to her. The other thing I will state that this program in itself is not intended to generate revenue for AMR. We're not charging any of the patients that are sent over to nurse nav. So what we would do is with you, whether you have clinics, whether you, I mean, there's all, the success of the program that I saw in Texas was that the directory of services for the county is what makes it a success. But that is something that all of us would have to build together. And, you know, one of the big ones that I saw was amazing too, was there was a surgical dental center that was one of the resource points that they had identified for a patient. And I got to watch from the beginning to the end where this person had called 911. This patient got pinged back and forth because of a dental issue where his tooth had come out, root and all. They ended up getting him to a surgical center, having his original tooth reimplanted. And when I was leaving that day, the clinic called back and said that had he went through a traditional ER, there probably wouldn't have been enough time for him to have his natural tooth replanted back in. So, you know, it was a big success story. I think in his case, there's a lot of great things that come along with it. But I do think that the success of it here is going to be us working together, identifying exactly how it's going to fit into the Monterey system. But a lot of great things, you know, with all of our agencies. I think taking a lot of the patients that we would normally AMA, it'll create a little bit, you know, additional bandwidth for the more, you know, high acuity patients that we would typically serve. And very open. It's not, I mean, I don't know if there's qualifiers, but I mean, the directories of services that I was looking at for, you know, like Contra Costa County, for example, is massive. I mean, they are working to identify as many resources for patients to build this phone book, if you will, of different resources for those patients. So it was great. It's a good program.
So one of my questions, on call, you don't get payer information until after the patient lands in the ER and they go through the registration process. Does that become a problem through the nurse navigation system? Or do you ask your payer status? So because, you know, urgent cares may not take Medi-Cal or whatever.
Correct. And the way that that's handled through the nurse navigation program is we will ask.
Okay.
But we frame it with the intent of not that we're going to bill you for this because we don't bill them for the navigation. We're asking them to make sure, hey, I want to get you to the right spot. So for instance, a Kaiser patient, obviously a Kaiser patient knows, yes, you're not, I'm a Kaiser patient, so take me here. For those patients who are uninsured or underinsured, then we get them to where they need to go and we work with our community partners to make sure that where we're sending them is somewhere that they are going to be able to get care based on what the information they give us is.
Yeah, and I think the point that I was making is just, for full transparency, it's just, there's no fiscal incentive for us other than the benefits that we gain as a system as a whole.
Right.
And the time on task that we have with our units going on these calls where they're doing AMAs or, especially calls that basically we're going a couple times in a day to the same patient for those issues, getting them to the right place. And I will say too, also, that is very significant. There were definitely a couple calls that I witnessed where these patients were still transported to the ER, by the way, not by ambulance, but by lift. That, they still wanted to go, but they said that they recognize they don't really need an ambulance. But even though the nurse didn't feel necessarily that they should be going to the emergency room, they did arrange that ride and still allowed them to go. So.
Dr. Burley, I had a question. Do we in Monterey County have access to 24-hour urgent care?
Sorry, I'm not sure the answer to that, whether there's a true 24-hour. Most urgent cares have specific times that they're open. I'm not aware of one that's open throughout the night. But I'm happy to be corrected if someone knows differently.
Yeah, I could say, I mean, most of them do close. I know in our system, we now have urgent care centers that are open, through prime care and an ortho urgent care. And we're extending hours, and then we have weekend hours for those as well. So I know a lot of systems are extending urgent care hours. And so it's just started. I know we have in our system, Salinas Valley Health.
Yeah, it seems like it'd be helpful in order for this program to work. It's one more place that these people could go get help. And if we don't have one that's open, then that takes that off the board.
One of our work groups is a community care resource work group, so that all the subject matter experts that live locally will tell us the type of urgent care. We've already done our research. We found about 18, but I'm sure there's more. So that's what that work group is about, is to make sure that we identify the most amount of community care resources to navigate our patients to the correct place.
Yeah, and I have a follow-up on that as well. So on your slide, Steve, you indicated that there's mobile integrated health resources and county care. I think it's called county care resources.
Community care resources.
Community care,
yes.
sorry. Again, back to the question, do we have those in our county to begin with? It sounds like we may have a few.
We've already done.
So that pretty much
Yeah.
answers my question.
So, I mean, this is something that I brought up at CCC, and I appreciate the fact that we're working on building this out, right? This is in turn, when you look at at any kind of program that utilizes alternate destination, it's all well and good if you have sufficient alternate destinations for patients to go to. And if you don't, what are we doing? And so that's going to be an essential part of the success of this program, as Mike and Steve have already kind of brought to light. And so we do need to build out a robust model like Contra Costa has, where you have as you describe, almost a phone book, a litany of different alternate care destinations that can be utilized for different situations. I know, this is not just pre-hospital, right? This is in the emergency department. I spend probably 85% of my time doing things that they don't need me to do this. I'm trying to arrange for the patient to follow up with outpatient dental, or 1,000 other things that doesn't require an emergency physician to do. But it falls on me because there are no other resources that are going to step in and do this for this patient. It's my job as part of the safety net to get this patient to the resource that they need. And so often it's not an emergency. It's simply they don't know where else to turn, and we're it. And I respect that, and we do the job. But if we can build out a system where patients are sent to the right facility and the right resource at the beginning, that saves the ED time and staff. I think the dental emergency is a great example. We're really good at a lot of things in the emergency department, but we're not great at dental emergencies. I'll be the first to say, You know, if someone needs me to put in a bridge and you really get in there and do a deep root canal, that ain't me. So, I am happy to turn that over to someone who can do that. With understanding there are our limitations in time and resources. So, I think, again, it's all in the, it's all in the details and getting our alternate destinations in place and continuing to build them as you kind of talked about phase 1, phase 2, phase 3. This is not something that's going to open on a Monday and we're going to have everything in place and it's all going to work completely, 100%. But as we develop experience, as we build our resources, then hopefully we have a lot of places to refer patients so they can actually get better care than they would get in the emergency department for specific things that we don't do well in the ED.
And that's exactly what Eileen and Lisa and their team, they've done for all the sites you saw, is they have sat down with the local stakeholders and said, okay, this is what we found. Here's the boots on the ground. Tell me, what do you have? And working with everyone to make sure that you have as big of a system, a more robust system of community care resources to get them to. So it does work that way.
Okay, and then my question is, we've all been in that phone thing where you call someone and you get transferred, and I know you had mentioned that they could talk to 911, who could get transferred to the nurse navigator, who could then deem it that it needs to go back to 911. Is it truly a transfer, or is someone physically staying on the line with them and saying they've been at nurse navigation and we're sending the call back? Because you know how you can go between a call center in Texas and one in Washington, and you're never going to be able to have somebody that's kind of following what's going on without that frustration of being on the phone much longer than you feel you should be when you're not breathing well. Is
So-
that something that they're kind of hand walked through?
They are, and that's something that's addressed in those work groups of how the local PSAP would like to handle that. Would they like it to be a warm transfer of nurse getting back on the line with them? Or are they going to just send it right back? That's something that we work with. We can also do, we have the ability to, as this grows, implement a CAD to CAD system so that the nurse can send it right back over and it's already geolocated. It's already been EMD. There's no need to go through and ask those questions. They're not calling 911 again. They're just getting back and getting apparatus dispatched to a call that's already in the system. So, well, exactly. And that's the reason for that, is because we don't want people to have that experience. Because if they have that experience, they're not going to be happy with it and they're not going to use it.
Thank you.
And it's very detailed. I mean, I have to say, just going back to the resources, I watched one call that was being processed in Contra Costa County, and the nurse was trying to identify an urgent care. The patient, had a couple urgent cares that they thought that they'd like to go to, but the nurse actually was looking for urgent cares that might have radiology, the ability to do x-rays. So that was a big question that came up, and said, I would feel more comfortable if you went to, one of these here. So it really is just, it's dependent on how many you can build into the system. But it's a great program. And I did get some, watch some of the calls getting shifted back to 911. But it was also very helpful, I think, that in the one call that I did see where they sent an ambulance, it was a BLS ambulance that just went out code 2 after that. And yeah, it was a great program.
Miss Spencer, I know you said you had quite a few. Could you give us maybe a sampling of what those questions are, just so we have kind of a feel for what the hospital's positions are?
Well, referrals was one of them, what is that clinic system and are they going to partner with the community? So that was one. Quality, how do we monitor quality of the calls and care, and, what is that process if something doesn't go right? Because what we know is that somebody may call with a mild symptom that's actually a life-threatening one, right? So what is that quality control behind the care? I had billing and patient cost questions. And then, pediatrics, process around peds. Are they included in that? How do we work that? Because they, as we know, are extremely vulnerable, and mild symptoms can be life-threatening. So those are just.
Appreciate that.
Yeah.
Yeah. So some of the questions I have is, First, the timing, what we anticipate this to be within our system here. Is this day one or is this day 6 months or 1 year, or do we have any indications of that?
I mean, I think that just as a gauge that, the reality is that there's going to be 5 work groups. One component, for example, is just the communications piece, the call flow. I think it would likely be a little bit too aggressive to happen by February 1st, just, knowing how many different work groups and, looking at the determinants and protocols, identifying all of the facilities and the clinics and those types of things, and looking at, the QI processes as well. So I would say that, we obviously, it's an essential part of the 911 system for us. It was a big part. We designed our system around NurseNav for the new contract, but I will say that we want to, implement as quickly as possible, but at the same time, not overrush things as well, because it's going to take a little bit of time, especially building the directory of resources out there. And that's what will make the program successful. But all of those things, I mean, the communications piece, how fire is going to respond, it is a change to some aspect. So we'll have to work through all of those things.
Mike, you don't have a target goal within your business of, we'd like to see this implemented to phase 1 in the first quarter of whatever?
Yeah, we initially had planned to be implemented by February 1st. So things have been a little bit delayed with Teresa being out as well.
Sure.
So could be as soon as March, April.
I get it,
Chief,
things may change.
Oh, sorry, I think it's reasonable to say probably within the first half of 2026 as a goal. A lot of that will depend on the progress within the working groups. So we want to get obviously input from as many stakeholders as possible. So we want to be sort of responsive to that input and make sure that we're not pulling the trigger too early to implement this, and that we're, gathering as much information and taking the time that we need to do this correctly.
Sure.
So there will be hiccups and bumps along the way, just like with any new program, but we want to minimize those as much as we can.
Yeah, makes sense.
And it's hard to predict, I think, out of those 5 work groups, what the barriers might be as well. So I think until we've, had all 5 groups meet, probably not until then we'll have a better idea of, exactly what the implementation timeline is going to look like.
So Mike, we received a report today that about 70% of the calls are getting to EMD. I'm not quite sure what that means, but it sounds like they're getting at least to it, maybe through it. Of those 70% of those calls, what do we think is going to be, based on your data that you have, will be diverted into this program?
Well, I think in Steve's presentation, there's different phases. And I think that it could take reasonably a couple of years to get to full maturity. The numbers we were looking at for Monterey County just through ESO, and an estimate and assumption could be that 19% of those calls could go to NurseNav.
About 19% of the 70 that actually get through EMD.
Yes.
Okay.
Yeah, but it could take, I don't know what the timeline would be like. I'm not really sure exactly, I haven't worked in NurseNav myself, and I don't really know what the phases of maturity are, but initially, it's probably going to be a very low percentage. I think what we'll see, probably in the 3 to 5% range, I would expect.
Chief, I'd say your first year, you're looking at probably 5% of that 70% that are getting through. How you grow is up to the entire system. Some systems come online and they're just out the gate going. Some take a little while. So it's really up to the stakeholders within the system to determine how fast you want to grow that.
Okay. Last couple questions I have. First, policy implications. Obviously, there's some policy implications to this. And if we're looking at starting this the first half of 2026, what is the process that we're looking at for that? Just so we can make sure that, it's gonna be off cycle, if you will. I'm not quite sure. I just want to be able to provide feedback to our employees with that.
Yeah, the 2026 policy and protocol cycle is already underway. So those would go live July 1st of the coming year. Any changes would have to be off cycle. A lot of it's really going to be driven by the work done in the working groups and what the identified needs are. So I would anticipate there will be some changes to clinical protocols, policies. I'd also anticipate potentially some changes to the dispatch related policies and I think we just have to be open to working through, the changes as they come up. And then there will probably be more changes that we need to make after implementation down the road as we evaluate the data that comes back, the quality that we're delivering, and what the system may need further. And then as we potentially look at expanding and branching out into those different phases that Stephen was talking about.
Deborah, what are the working groups, or Mike?
I apologize. I don't know them off the top of my head.
Okay.
I mean, there's definitely one that identifies.
I understand comms is one.
The ones that I have are clinical determinants. So that'll be a primarily, obviously, clinical driven, medical director participation, and other key stakeholder participation. Call flow, which will be very focused on dispatch policies, that sort of thing, and then tying into responses as well. Community care resources, which is the group that Eileen talked about, as far as identifying and coming up with that phone book of resources for the area. And then community education, as I think Stephen pointed out during his presentation, there can be some resistance to changes to the normal 911 practices. So working with people like the health department PIO, maybe fire agency PIOs, that sort of thing, to get the information out to the community in advance of the implementation so that no one's surprised. Well, as few people as possible are surprised by the change.
That's for, is there a first responder one in there somewhere, or where would they land?
I would see the first responders integrated throughout those. So I don't think necessarily an individual first responder, unless Eileen or Stephen has different experience in different areas.
No, there's only four. Four, yeah, there's only four. But, and you were correct, they were all correct. And each stakeholder can go to all of them, join all of them, or just join specific ones to their subject matter expert. It's up to you. We'll take as many people as we can so that we have this program ingrained into the system that you guys built.
And those are established and already.
No. We'll be recruiting for membership. Yeah, I guess I don't see first response as necessarily being shoehorned just into clinical determinants or call flow or anything like that. I really see that crossing over and having needs to be involved in the various groups. So that's kind of our perspective working on it.
And we have it charted out as far as all the representatives, and I think that that's fair. We can share that with you as well, so you can kind of see.
And then the final question I have is, how does the money work? How do you guys get paid, or nurse staff get paid if?
It was built into our patient charges.
Okay, so it's already built into
It's
the
already built
fees.
in, so that's basically how the entire system is funded.
Thank you.
Good. I've just got a quick question. Thank you, Chief Sargenti, for your questions. From a city manager's viewpoint, I mean, the hospital thing and the ambulance thing, that's awesome. I'm wondering what the fire departments, emergency services, people at the city or regional districts, how does the impact of the 19% of the 70% reduction in calls potentially, does that a one-to-one correlation, you think, with the fire districts or departments, or I'm sure either that or less?
You know, Paul, I think it depends on the system you're in. If you're in a higher volume system, such as the city of Salinas, I think they could probably see some relief in that. I think if you look at our district and our lower call volumes, I don't think we see as much with regards to that impact. As time and circumstance goes, this is my kind of first blush at the program, so I'd kind of have to analyze it a little bit more.
Thank you.
So Mike, you said you would share who you have outlined,
Yeah,
stakeholders?
we have
so
not
far?
identified exactly who's on the committee, but we definitely have identified who the representatives would be in those work groups.
Okay,
Yeah,
and you'll share that with us too?
absolutely.
Great, thank you.
Great.
Nothing else?
Any other questions?
I just want to make a comment, a little bit of Groundhog's Day for me with this. It's a long time coming, and appreciate the presentation. I appreciate the questions and appreciate all the information. All my questions for now seem to have been answered. And I would just say, going back to where we started going down the road with MPDS a number of years ago, that talking about the system as a whole, to answer your question, Paul, for us, over 15,000 times a year, we do this. We have the opportunity to eliminate, I'll take 2%. I'll take whatever we can get out of it. Our resources are stretched that thin, so appreciate all of this good work and this good conversation. I'm looking forward. Save Salinas a front row seat for this, please. Absolutely. Thank you. Thank you.
And I'll just chime in on behalf of the ED physicians out there who are taking care of those dental pain patients. I appreciate it.
Thank you. Okay, moving to item C, new business, Seneca Center, Jenna Fortis.
Yes, I can take over with an introduction for Jenna and Amanda, who's also joining us from Seneca. I will introduce Jenna and then let her introduce Amanda and turn things over for their presentation. So Jenna Fortis is the Assistant Director of Nursing for Crisis Services across the Ventura, Monterey, and San Francisco County Crisis Continuums at Seneca Family of Agencies. A dedicated and compassionate leader in pediatric mental health, Jenna has spent the past decade deeply committed to crisis intervention, trauma-informed care, and ensuring dignity-driven support for vulnerable youth and families. She has played a critical role in expanding access to high-quality mental health care for children and adolescents experiencing acute psychiatric crises. Jenna began her journey with Seneca in 2016 and was instrumental in launching the Ventura County Crisis Continuum. Her clinical excellence and steady leadership quickly earned her the role of lead nurse, a position she held for over 5 years before advancing to nurse manager for another 4 years, and now to her current role overseeing crisis services across multiple counties throughout the state of California. Known for her calm presence, collaborative leadership, and unwavering commitment to Seneca's mission of helping children and families through the most difficult times of their lives, Jenna continues to shape systems of care that prioritize safety, empathy, and resilience, and is looking forward to supporting the crisis continuum in Monterey County. With that, I'll turn it over to Jenna.
Thank you. Gosh, this Jenna sounds great. I am also actually wanted to announce that I am holding the interim program director position until we are able to hire for that. So, you know, lots of hats right now. And I'd like to introduce Amanda Kipp. She is a standout CSU crisis nurse since May, since we started hiring for these programs. She's been integral in the startup of these programs. So happy to have her with me today. And then for the interest of time, I don't want to talk too fast, but I just want you to know I did forward Deborah our contact information. Please feel free to reach out to us one-on-one, or if you need any other presentations. And we also have 3 handouts there. One is a flyer, one is the medical screening checklist that we will go over, and the other is like a ED information sheet. So please feel free to look at those. So our philosophy at Seneca is unconditional care. It is a commitment to do whatever it takes to support the young people and families we serve. No matter how profound the difficulty faced, we will be there every step of the way. Our program description is really important. We are a 23-hour, 59-minute facility. It's a crisis stabilization unit. That means that clients stay with us up to 23 hours and 59 minutes, unless their disposition is to go inpatient or, there's a delay. They can stay with us longer. We don't just kick them out the door at the 23-hour, 59-minute mark. We are unlocked, and we are a specialty mental health program. We can take up to 4 youth at a time, and they do need to be medically stable. So we can figure that out. Maybe they're coming from an ED and the doctor has said that they're medically stable, or that's why we have registered nurses, so they can say that they appear to be medically stable through our screening questions. Referral parties right now is our own mobile crisis response team, Monterey County behavioral health clinicians, our post-hospitalization team in the county, Sierra Wellness crisis response, and emergency departments. We serve 6 to 17-year-olds who are experiencing a mental health crisis, and they do have to be residing in Monterey County. We have a multidisciplinary team staffed 24/7, 365 with clinicians, registered nurses, telepsychiatrists, and youth stabilization specialists. And then we've been really lucky in the hiring process. So we do have 24/7 bilingual capacity. We serve Medi-Cal beneficiaries and uninsured clients, and they do need to be voluntary at this time. The assessment process, I'm going to pass over to Amanda. Oh, you're on mute.
Thank you, Jenna. So our youth will start the process with us by meeting with a registered nurse and a licensed or registered clinician, and we will perform an in-depth intake assessment. We start off just by a simple handheld metal detector to ensure safety for the youth and our staff. We offer comfortable clothing, and then we proceed with vital signs, height and weight, and an overview of their medical history. The goal of this is just to identify any potentially underlying medical issues that may be contributing to their current crisis. And then we gather all this information and work with our interdisciplinary teams to make recommendations for medical follow-ups or continuation of medications as needed.
They move on to the clinical assessment with a registered or licensed clinician who will be assessing immediate safety such as stressors, triggers, conflict, any history of trauma, abuse, or neglect, any new onset of mental health symptoms, and any changes in thinking, behavior, or feelings. At the same time, then one of our other staff will be gathering collateral information from anyone really who the client knows best, who knows the client best. Caregivers, family members, therapists, psychiatrists, their outpatient team, if they have a social worker, probation officer, and a school counselor. And so what we do is we put all of that information together and we make a determination about what the next best step is for them. At this time, we only have two options. One is that they are committed to safety and they can be cleared for discharge after they meet with one of our psychiatrists. And that's really like they're connected to mental health services. They have an ability to engage with natural supports. But on the other hand, they may meet criteria for a higher level of care and they may need an inpatient hospital. So we will be transferring them to an LPS facility, and that would be Natividad or CHOMP at this time. And that really looks like they're unwilling, unable to keep oneself safe, not connected or disengaged from mental health services, inability to identify or even lack of natural supports, and then possible like serious suicide attempt. So our stabilization services are ongoing, but it includes 1-to-1 staff ratio when needed. We do crisis communication, de-escalation, anything really under the crisis intervention realm. We have individualized care plans, we safety plan, we do aftercare and discharge meetings, and that includes the client and their caregivers. And then it's just an ongoing collaboration and consultation with the multidisciplinary team as the disposition for them can change at any time. Follow-up services right now, this isn't an exhaustive list, but post-hospitalization team, MCBH referral, Seneca's, our very own MRT program referral where they can follow them for 30 days if they do an intake. And we really just assess for all unique needs and make appropriate referrals.
So once you identify that a youth might be fit for our agency, you just contact us at the number listed above here. And that, like Jenna said, is maintained 24/7, 365 days of the year. And that will get you direct contact with one of our CSU nurses. And at that point, the nurse is just going to ask some general demographic information, the nature of the crisis, find out safety risks for this youth, and then we'll go through a medical screening checklist, which I'll show you on the following slides. The nurse will also make a quick call to the caregiver and just do a brief COVID screening since we are still trying to keep everyone safe in that regard. And then we will gather all the information together and determine if it's a safe or appropriate fit for our unit. And we will call the referring party and find out how the youth will be transferred over to us. Once the youth arrives, the nurse will meet them at the ambulance bay and just revisit some of those initial screening questions, do a brief visual assessment, making sure that nothing transpired in the course of transportation or any changes happened, or maybe something was not disclosed that may need to be looked at further by a medical professional. Examples would be if the youth had self-harmed and there was an open wound that needed closure and we were still in the 24-hour window, or if there was a head injury, they started becoming more really anxious, banging their head in the car ride over, etc. And if that does happen, the nurse will request that the youth is sent to the emergency department for medical clearance. And then that kind of changes things, and the emergency department will contact us to send the youth back once the physician deems them medically cleared. With all this being said, I just really want to emphasize that we want to serve as many kids in our community as we can. So we really do try to work closely to make sure that it's a safe fit and that they can be on our unit safely. And we don't typically send many people away as long as they don't have any obvious medical concerns that we can't safely address. This is our checklist, and Jenna has made them available to all of you, a printed copy, but basically none of these are really exclusionary criteria. These are just ways that we can make sure that we're going to be able to meet the youth's needs once they're in our facility. So we like them to walk, eat, talk, and toilet, but if for some reason the child still has accidents, we could, an example of a workaround with that would just be talking to the youth's caregiver and seeing if they feel comfortable, giving the youth like very specific instructions on how to keep clean while they're in our care. And if that all works out, we could accept them. So like I said, these aren't all exclusionary, just things to have a better picture of. Another example is disordered eating. If a youth hasn't been eating, we might want to have them have some labs drawn before they come, just so we can make sure there's no major electrolyte imbalances going on there. So I'll just skip to the next page. I'm not going to go over each one individually just because we're a little short on time here today, but again, when you're reviewing these or when you're seeing these, I hope that what you take forward from this presentation is, even if something pertains to the youth, that they still may be able to come on our unit. We try really hard to get everybody on and welcome. Go to the next slide. Thank you. So this is a picture of one of our day rooms. We have 4. There are private day rooms, 1 client per room. They all have a beautiful view, lots of natural light, a big comfy chair, and then a place for the youth to lie down if they prefer to do so. We offer lots of food. We give the youth choices. Meeting their basic need with food is often huge in crisis situations with kiddos. So we do offer lots of snacks and things. And then this is our triage room where we would first meet them with the nurse and the clinician, and we just get them comfortable, offer fidgets and any comfort things they might need so that they feel like they can open up to us and share that information. And this is a picture of our lounge, kind of our milieu area where our staff work one-on-one with the kiddos, or they also can interact if there's more than one kid there at a time, playing games, art projects, working on some CBT materials, whatever's been recommended for that youth.
This is our contact information. Dawn, some people are probably really, aware of her, and she's our regional executive director. And then my name is there as well, but I did send this contact information to Deborah so she can send it out. And that is our facility, our address, telephone, fax, but on all the paperwork that you have, you should have all the contact information of how to get there. And then any questions?
Hi, Jenna, Steve from the EMS agency. Quick question on the process flow chart that you had. It has a item for secure transport. What is that?
Just that we secure transport to the facility. I know what you're talking about.
It's not secured transport, it's you have it available.
Yeah, We do not have transport available. Well, it depends.
Well,
It depends on how they're coming from us. We could
To
take
arrange
easy.
transport.
Yes, arrange. But we do have a lot of our referrals are coming directly from our MRT team who does have transport. And they can follow the caregiver.
Great, thank you.
Yes, of course. If anybody thinks of anything, you can reach out to me directly. We love doing these presentations. We also love to tour our facility as well. So that would be really great. Reach out and we can accommodate that. It just depends on if we do have any clients at the time. But we'll always, make the time.
All right, thank you very much.
Yeah.
Please go ahead.
Are they open now?
We
Taking
are.
patients?
We are.
And you have patients?
Not right this second, but yes, we have
Oh,
served
okay.
clients. Yeah, we have.
Great.
Yes.
Thank you very much.
Yeah, of course. Thank you.
All right. So moving on to announcements for the good of the order. Any member of the committee may make announcements or comments. The EMCC may not discuss or take any action on any item raised during the announcements, except to decide whether to place the matter on a subsequent agenda. Are there any announcements for the good of the order?
So I just have one, Will, and I've been working with Deborah on this. The first responder exposure program or plan, if you will. We had a firefighter that was exposed and was transported to NMC. And there was definitely some challenges trying to get the data back from the NMC program into our back into our system, at least for the employee themselves, and then through our workers' comp program and those type of things. So appreciate the help that Deborah's already provided. It sounds like we may be heading down a path of consistency and collaboration between the hospitals and EMSA and in a policy direction. It's not really a matter of when these will happen, or if it will happen, it's when. And I'd really like to try and clean that up so that we're all on the same page and be able to get the results back to our employees as well as close the loop with the workers' comp process. So thank you, Deborah, for the work you've already put in.
Yeah, we'll continue working towards a policy. I think there are some good LEMSA examples out there that we can borrow from, and I've had some conversations with county council, and as anybody working in the facilities knows, it's not a straightforward question, and the answer depends a lot on the specifics of the circumstances. So I think any policy guidance that we can put in place will be helpful.
Well, thank you for that. All right.
Before we move
Yes.
on, just a quick, Deborah had mentioned this earlier in her EMS director report, but I just wanted to put a shout out to Natividad who passed their ACS trauma review with flying colors, no deficiencies. They put a lot of work into it, and they presented very well, and the reviewers were very impressed with the level of care provided. So congratulations to Natividad for that accomplishment.
Thank you, Dr. Burley. Any other announcements? All right, so we'll adjourn. Next meeting is scheduled for Wednesday, January 14, 2026 at 10:30 a.m. Thank you.